Good morning, everybody. It's May the 8th, World Ovarian Cancer Day, and we are here hosting a webinar called PARP Inhibitors and Beyond. My name is Orla Dolan. I'm the CEO of Breakthrough Cancer Research, and we are a cancer research charity that focuses exclusively on research, and we also provide evidence-based education and information. And ovarian cancer is one of those cancers that we focus on in terms of our research. I'm delighted to be co-chairing today with Dr. Sharon O'Toole of Trinity College Dublin and Ovacare, who will shortly be introducing our two amazing speakers, Dr. Dearbhaile Collins and Anne Herlihy. A little bit of housekeeping up the front. We will be offering the opportunity for questions to our speakers, but we ask if you put them in the Q&A and the chat box, and then we will do them as an overall panel at the end. So for now, we just want to say thank you very much. I will hand you over to Dr. Sharon O'Toole, who will again introduce our speakers and tell you a little bit about some other campaigns like T-Lights that are going on today for World Ovarian Cancer Day. Thank you.
Thanks, Orla, and I'm delighted to be welcoming you all here today on World Ovarian Cancer Day. And just to say, so I'm a scientist in Trinity College, but I also sit on the board of Ovacare, and Ovacare is an ovarian cancer support charity. And after this webinar, Ovacare will be holding one of their monthly coffee and chat events. And this is where patients can just meet in an informal setting and have a chat about their treatments and various tips and share stories. So I'm going to pop the email address of Ovacare into the chat box. If any of you want to join us afterwards, you're more than welcome. We'll send on the link to that event. Also, just to say, we have a number of buildings around the country lighting up in teal tonight. So we have buildings from all over the country. And we're also encouraging people to join in a tea lights campaign. So just to take a picture of a tea light, if you have an actual teal one, that's great. If not, any tea light will do. Just post it with the hashtag tea lights. So we would welcome you all to join in that later on tonight. So now, without further ado, I'm going to hand over to Dearbhaile Collins, who's going to talk to you about ovarian cancer treatments, PARP inhibitors and beyond. So Dearbhaile, I'll hand over to you.
Many thanks for the invitation to speak today, May the 8th, World Ovarian Cancer Day. My name is Dr. Dearbhaile Collins, and I'm one of the consultant medical oncologists in Cork University Hospital, and I have a speciality interest in gynecological cancers, including ovarian cancer. So today I was hoping to discuss ovarian cancer overview briefly and introduce some key points in understanding how PARP inhibitors work, who they work well or best on, and some of the side effects that they may result in. So this includes some concepts about how we repair our DNA as our cells divide, and also discussing BRCA mutations and what we call HRD scores, which will come to mean a lot when we discuss PARP inhibitors in the future. I'm going to discuss how PARP inhibitors work, as I said, why and when we use them, some of their side effects, and also some of the trials that are ongoing that will hopefully answer some of the questions we have about PARP inhibitors and whether they can be combined with other agents.
Hi everyone, we seem to have a bit of a technical issue there with Dearbhaile's slides that are not changing forward. So if you can just give us a second, then we'll just get that going, because the sound is moving but the slides aren't. So just give us 2 seconds and we'll sort that out for you.
So apologies for that. So I was trying to prevent a technical problem by having the talk recorded, but it looks as though we've still hit a wall. So if it's okay, I think I'll just present it live, and that will just help. I was trying to prevent any instructions. So can that be seen, and can everyone hear me?
Yes and yes.
Great. Okay, fabulous. So again, apologies. So I thought I was being smart about preventing glitches like this. So you've heard me talk about what I'm going to talk about today, and they are just trying to introduce key concepts so that we understand how PARP inhibitors work and who they work best on. So this was the moving forward to the slide of what ovarian cancer is. It's very much an umbrella term. These cancers do originate from the ovary and from the fallopian tubes, but they are wide-ranging. They behave differently depending on, I suppose, their biological profiles. And like a high-grade serous carcinoma, which is in the blue pie chart here, behaves very different from, let's say, the green carcinosarcoma, the clear cell carcinoma. And this is important when we talk about ovarian cancer because we use the term broadly, but ultimately it's the specifics about the cancers themselves that are needed to be understood for how they respond to treatments. And one of the I suppose the ways in which that dictates how these cancers behave are the mutations that are within them. So if we look at high-grade and low-grade serous cancers, mucinous serous clear cells, these are all ovarian cancers, but they all look very different when we look at their mutational signature. So the problems that are within the tumor themselves that cause them to be cancerous and that cause them to behave the way they do. So if we take TP53 in the blue bars, KRAS, these are common mutations that we see in some of these cancers, you can see that they're very diverse and different across the different groups. And this explains the different behaviors in biology. So one of the other key concepts that I need to get across, I suppose, is the sensitivity of cancers to chemotherapy. So we use chemotherapy, you know, it's almost the backbone of the treatment for advanced ovarian cancer. And advanced being, I suppose, stage 3 and stage 4 cancers tend to be relapsing, remitting diseases. They tend to have periods where the cancer becomes active. These are then managed with, this period is then managed usually with chemotherapy, in particular with a platinum chemotherapy, a drug usually carboplatin, but occasionally another platinum. And that period, or that active period, is put back into remission or dormancy, or where the cancer is supposed under control for a period of time. And that period of time is called the platinum-free interval. And the length of that time usually dictates the response to treatments the next time. As the cancer progresses, it can often develop resistance to chemotherapy. And this remains an area of significant unmet, I suppose, need. And we do need better treatments for patients once the cancers become resistant. And once that resistance kicks in, it is harder to get the cancer back into that remission period. So the platinum-free interval that I spoke about is the time from the last carboplatin until the time that the cancer becomes active and requires more chemotherapy to get it back under control. In general, if that time is 6 months or more, giving carboplatin again is important because the cancer cells are likely to remain sensitive to the carboplatin. But even if it's only 4 or 6 months, there is some partial sensitivity. It's when the chemotherapy doesn't work that we start running into trouble from treatment options. So the key to, I suppose, improving patients' outcome is trying to increase this platinum-free interval by using maintenance treatments. And ovarian cancer, chemotherapy has very much stayed in the active treatment part of the cancer journey. But these maintenance treatments are really starting to come to a fore. We've been using anti-angiogenics, or a drug called Avastin, for a long time. But PARP inhibitors most recently have really come to the forefront as really successful and active agents in maintaining this remission. We also sometimes use hormones, and there's a lot of other diverse compounds currently under investigation. So the focus here today is going to be PARP inhibitors. And before I go into the PARP inhibitors themselves, they work by, I suppose, utilizing how we repair our DNA. So cells in our body need to replicate, and to do that, they need to transcribe, or they need to copy, the DNA recipe that resides within all our bodies. So this replication happens all the time, but mistakes actually happen with this replication process on a pretty regular basis. So mistakes are happening as the body is copying one strand of DNA to another. This is just chance most of the time, but occasionally it can be driven by things like UV light, chemotherapy, radiation. And there are many different mistakes that can be made, but the body has an incredible inbuilt repair systems, because there are multiple systems that can come into play depending on the mistakes that are made. And this prevents those mistakes from being passed on to the daughter cells. So it's these DNA repair mechanisms that are key to ovarian cancer and its development, but also how the PARP inhibitors work. If we look deeper and closer on a molecular level at these DNA repair mechanisms, I'm not going to go into it in detail, but you start to see proteins that we recognize, like BRCA, which is a DNA repair protein. We start to see PARPs. We start to see other proteins that are being utilized for treatment and for diagnosis. So just to touch on BRCA1 and 2, it's, I suppose, the most famous inherited, in some instance, mutation that can result in ovarian cancer, as well as other cancers such as breast, prostate, and pancreatic cancers, but most commonly ovarian and breast. So BRCA1 and BRCA2 are involved in all our bodies in repairing DNA. But if they develop a mutation that prevents them working properly, that's what leads to the risk that our DNA no longer picks up those mistakes and can result in cancer. If BRCA1 or 2 is genetic, so if it's within your germline, if you were born with the mutation, and that can be men or women can have this, it can pass on to your children, and it has a 50% chance of doing that. It is a dominant trait. So it is a really important mutation to pick up and to be able to diagnose, and therefore then prevent future cancers. The impact is significant. The general population has about a 12% risk of developing breast cancer, but if you have a BRCA1 mutation, that can be as high as 80%, or BRCA2, 70%. Same with ovarian. But importantly, it's not just women that are affected by a BRCA1 or 2 mutation. Males can develop breast cancer, prostate cancer, and pancreatic cancer, as well as female pancreatic cancer, driven by these BRCA mutations. So definitely something that is really key to diagnose. So in ovarian cancer, about 15 to 18% of ovarian cancers are driven by an inherited BRCA1 or BRCA2 mutation. There is another proportion of just a BRCA1 or 2 mutation just in the cancer itself. It's not inherited, can't be passed on. It's a BRCA1 or 2 mutation that's developed, and that's resulted in the ovarian cancer, but it's in the tumor itself. So about a quarter of high-grade serous and endometrioid ovarian cancers are being driven by BRCA. There is another concept. There is a silencing of BRCA. It's not a mutation. It's where they can be silenced. So really BRCA probably plays a role in up to 40%, but the relevance of the silencing is still being kind of worked out from a research side of things. There are other inherited mutations that can result in ovarian cancer, other genetic drivers. These are rare, add maybe another 6%, and they are wide and varied. So even if you do not have a BRCA1 or BRCA2 mutation, but there is a family history there, a worrying family history, you should see an oncogeneticist, so a genetic specialist. They're based in Crumlin and James's at the moment, who specializes in cancer risk because they can screen for these other abnormalities. So as I said, the germline mutations on the left are in your DNA itself, can pass on to your children, but the tumor itself can have the mutations, and that this is not inherited, but this is what's happened to cause the cancer in the ovary. So these are pretty wide and varied. So in the cancer itself, this first part of this pie chart is the inherited BRCA. This little bit here is the somatic BRCA, followed by methylation or silencing of the BRCA. So this is the 40% of BRCA mutations, BRCA problems. So then there's this next group of mutations that exist in the cancer itself that are caused by, or that are resulting in the cancer, and it's a problem with DNA repair mechanisms. There's also other abnormalities in the cancer themselves, all tied into the DNA repair. So probably over 1 in 2, over half of high-grade ovarian cancers are being driven by a problem in the DNA repair pathway. And we call that HRD positive, HRD high. It's where you have a problem with your DNA repair pathways, usually in the cancer itself, but sometimes, as I said, sometimes inherited. And it's not just ovarian cancer that this HRD comes into play. And so these are the potential, you know, in ovarian cancer, it's obviously over half, maybe more. Breast cancer is probably about 20% of these cancers have a problem with their DNA repair mechanisms. Pancreatic cancer is again about 20%, and prostate about a third. So PARP inhibitors, which are used to, I suppose, try and work in these patients, will, while they've led the way in ovarian cancer, will also come to the forefront in other cancer types. So in Ireland at the moment, we have BRCA1 and 2 testing in both the germline, so your inherited risk, but also the tumor itself. And this is standard of care. So this is done at diagnosis when you, irrespective of your family history, irrespective of your age, every person should have their cancer and their genetic and their germline tested for BRCA1 and BRCA2 as part of their treatment. And if you haven't, or if you know, always check with your oncologist that this has been done. It is high-grade serous and endometrioid cancers that we're testing at present. And your oncologist, the NC is being led out by the NCCP, but supported obviously by the HSE. There is another scoring system that I will mention as I talk about some of the results of the PARP inhibitors. And this is called the HRD score. This really just measures how unable the tumor is to repair its DNA. So how genetically unstable the cancer is. And this HRD score determines the cancer's ability to repair the DNA. So there's a couple of ways, or a couple of tests that exist as a myriad score, foundation medicine score, but ultimately it's one of the main parts is the test for BRCA, and then they have other ways of assessing how unstable the score is. This is not available at the moment in Ireland. We are in discussions with the NCCP about how we would introduce this and who we would introduce this for. You can purchase it, you can buy it, but currently I wouldn't recommend that because it's not having a direct impact on the treatments that you can access and receive at present. Although as we move into the future, it may, and that's why there are conversations currently ongoing about these tests. So there's a lot of PARP inhibitors out there at the moment. Lynparza or olaparib was sort of, I suppose, the first horse in the race, and it is available for BRCA patients after they've finished their first chemotherapy. We've had Rubraca available as compassionate access for a number of years. We now have Niraparib available for prescription. Anybody can prescribe Niraparib for high-grade serous ovarian cancer, but importantly, it is for platinum sensitive. Talzena has recently been approved for breast cancer with a BRCA mutation. So these are coming, and there's more that exist. So how do PARP inhibitors work? So PARP's whole purpose is that it detects mistakes, specific mistakes that are happening as the cell is replicated, so mistakes in the DNA. So if you inhibit this, if you take a PARP inhibitor, basically that mistake then gets passed on to a daughter cell and becomes a double-strand repair, so a different type of mistake. So a different pathway of DNA needs to kick in and fix this. And if you have a normal cancer cell, then that happens, then that is fixed, so the cell survives. But if you don't, if your cancer cell has a problem with its DNA repair, if it's got a BRCA mutation, a PALB2 mutation, something that's making its DNA repair, ineffective, then it cannot repair this mistake, and the cancer becomes so abnormal that the body gets rid of it. So the cancer cell is destroyed. So we use a kind of a table analogy to try and explain this in a more obvious way. So if you've got a four-legged table and you've got the legs are your DNA repair mechanisms. If you give a PARP inhibitor and you take out one of those repair mechanisms, if you have a functioning HR repair pathway, so if you have a normal cell, you don't have a problem with your HRD or your DNA repair, then the table doesn't really matter. It's still standing on its three legs. But if you have a BRCA deficient or a HRD positive cell and you already have lost the legs, you're starting out on the three-legged table, and then you give a PARP inhibitor, the table is no longer functioning. The cancer cell is basically defunct. So PARP inhibitors have been tested for years, and I was involved in some of the very early studies when I worked in London in the Royal Marsden. But ultimately, it was tested in many different cancer types and all types of ovarian cancers at the start. But very soon, it became clear that patients with BRCA mutations were doing much better than those maybe that didn't, although it is improving for everybody. So SOLO2 was, I suppose, what changed our practice. That was giving PARP inhibitors after your second chemotherapy and only to BRCA mutated patients. And it significantly improved that platinum-free interval that I spoke about, prevented the cancers from coming back markedly. So from 5 months, improving it from 5 months to almost 20 months. Lots of studies happened very quickly. NOVA are the Niraparib studies, Ariel are the rucaparib studies, and these are Kaplan-Meier's that look at patients the platinum-free interval. So you can see for BRCA mutated patients, Niraparib and rucaparib are doing just as good as the olaparib was for SOLO2. However, what NOVA and Ariel showed us was that you didn't have to have the BRCA mutation. Even if you were just HRD positive, you were getting a significant benefit. And actually, to be honest, even if you were HRD negative and you didn't have the BRCA mutation, you're still getting a benefit. And this is the problem with HRD testing, is that while it is identifying a group of patients who are doing well, it's not picking up everybody. And currently we have access to these PARP inhibitors for all platinum sensitive patients, and I am exposing all my patients, as long as they maintain platinum sensitivity, to a PARP. So SOLO1, and it has changed how we, has recently changed how we manage the BRCA mutated patients, because now we are giving olaparib at their first diagnosis. So they've been diagnosed, you've had 6 months of chemo, you're going on to olaparib if you've got a BRCA mutation. And that's why the NCCP and the HSE have brought in newly diagnosed BRCA testing to identify these patients. And these are inherited BRCAs and just tumor BRCAs. But what's amazing with this study was that the patients received olaparib for 2 years. So this took them to this point. And we all worried because we thought that at the 2-year point, all of a sudden then this olaparib group would all of a sudden join with the patients who didn't get olaparib. But that didn't happen. So now here we are 5 years after these patients have finished their chemotherapy, and 50% of them have still not had a relapse. And while it's really early stages, but there's a possibility that these drugs are curing these advanced ovarian cancer patients, and they will never relapse. And that, this is the latest data we have, so it remains to be seen as things go forward. But I mean, it's incredible results. So there's been 2 very recent studies, PRIMA, which Ireland was involved in, and some Irish patients got on, showed that HRD positive patients with or without BRCA made up about 50%. That's what we expected. And these patients went on Niraparib after their first chemotherapy, again doing much better, but significantly, like doubling that platinum-free interval. But what's important is while the HRD positive patients are doing well, everyone was doing well. And these, importantly, was a high-risk population. So the patients who went on the study were at really high risk of relapsing. Their cancers weren't removed fully, or they had, high-risk features. So the Niraparib is having a benefit irrespective of your HRD. PAOLA-1 is, I suppose, the latest one to come, and that asked whether olaparib with Avastin, which we've been using for years as maintenance, was better than Avastin alone. And the answer was yes, olaparib and Avastin is better than Avastin. What we do not know, though, and what needs to be figured out is whether olaparib and Avastin is better than olaparib alone, because that data, those studies are ongoing, and we will know that. So importantly, really important here, is that the HRD positive patients are getting the benefit from olaparib and Avastin, but the HRD negative patients are not. And while we don't know yet, because we don't have a way of testing who's HRD positive or negative, and so this combination is not available yet for patients it's not reimbursed or licensed in Ireland. And until we have a way of knowing who's going to benefit, and we have either a HRD test or some other method, we shouldn't be giving olaparib and Avastin, because what's happening is there's all these patients who are getting no benefit, but they're getting a lot of toxicity with the addition of olaparib here. So the PARP inhibitors, people ask me, which is better, which one works better? And the answer is we don't really know. We'll never have a head-to-head, so we'll never compare rucaparib with niraparib with olaparib. And when we cross-compare trials, which is difficult to do because trials have different eligibility criteria, so different populations go into different trials. So you can't take them all as directly comparable. But they are strikingly similar. And really, we're probably not seeing a difference between the different PARP inhibitors. We are also seeing a benefit in all patients. It is a spectrum. So everybody seems to be getting a benefit, but definitely the BRCA mutated patients are getting the most benefit, followed by the HRD high, and then followed by other patients, which we've still no way of really knowing why they're responding. Side effects that we're seeing include mainly fatigue, nausea, and an effect on the blood counts, in particular dropping your red cells or anemia, dropping your platelets or thrombocytopenia, and dropping the white cells. There are differences between the different drugs and the different PARP inhibitors and side effects. For example, niraparib much more likely to cause high blood pressure and insomnia. Rucaparib seems to have a bigger impact on your creatinine, your cholesterol, your liver function tests. And so maybe as we move forward in the future and we start to have access to all these drugs for different patients, we'll be able to tailor the specific PARP inhibitor, not on its effect, because we do think they'll probably all be the same, but on their toxicity. And if you developed, for example, abnormal liver tests on rucaparib, we could switch you then to something like olaparib instead. We are seeing with niraparib as well, we are seeing more drops in platelets, more drops in white cells. So again, if that's something that's requiring dose reductions, maybe a change from niraparib to something else may be the right thing to do. There are rare side effects that are worth noting. Now we see them about 1%. So the PARP inhibitors can affect the functioning of the bone marrow and cause something called myelodysplasia, as well as causing a leukemia, quite an acute and aggressive leukemia. Now we see these as part of chemo anyway. So chemo, as you may remember when I talked about DNA repair mechanisms, can affect can make more mutations. And so occasionally we do see late cancers in patients who've had chemotherapy when they were quite younger. But again, it's very rare. So we are seeing this as part of some of the PARP inhibitor studies. It is worth thinking about, and your doctor will discuss it with. But on I suppose on the broader schedule, the benefits are outweighing this risk. The PARP inhibitors can certainly cause pneumonitis or an effect on the lungs. So any shortness of breath, it's rare, but any shortness of breath needs to be checked out. We manage the toxicities with treatment pauses, drug holidays, and dose reductions. We try and find a balance between the side effects and then the drug itself. When we did the phase 1s very early on, I mean, even very low dose olaparib had excellent results against cancer. So dropping a dose doesn't mean it's going to drop the effectiveness of the treatment. It's just trying to find that balance, because I suppose the benefit of staying on the PARP inhibitor is more important, but getting those toxicities under control. In general, some of the nausea and vomiting especially the nausea, tends to settle down over a couple of months. So it is worth sticking with the drug. There is a concept of, I suppose, resistance to PARP inhibitors. In some of these cases, these cancers are coming back despite having been exposed to a PARP inhibitor. And fascinatingly, what's actually happening in some of these cancer deposits is the BRCA mutation is actually mutating. And now you have a normal BRCA. It's incredible to think that could happen, but these reversion mutations are happening. And we're also seeing these resistance happening, let's say, in one place, but not in another. So, example, you might be on a PARP inhibitor, but all of a sudden one lymph node is starting to grow, but everything else seems under control. So it's definitely well worthwhile, if that's the case, managing what's growing with either radiation or surgery or an alternative treatment pattern, and continuing the PARP for everything else. Because it's often a mutation that's flipped, and once you remove that bit that's growing, the cancer remains in remission. So just to finish up on what, I have 2 more slides on just where we're going for the future. So what we don't know yet are whether PARP inhibitors work after the cancer has relapsed on a PARP inhibitor. And there's a study known as the OREO study, which is looking at this, and it's ongoing, looking at olaparib retreatment with patients who've already had a PARP inhibitor and seeing whether a second exposure can have an impact on the cancer itself. We're also looking at these dust adjustments to find a balance between toxicity and making sure that efficacy and cancer killing, I suppose, or cancer holding maintenance is continued. And the Newton study is hoping to answer this. As you know, and as you may have noticed, PARP inhibitors aren't working on everybody, and even patients that they're working in, sometimes the cancers are coming back. So the real focus is how to harness combination treatment. We talk a lot about immunotherapy for other cancers. Immunotherapy has not been great for ovarian cancer. It's got about a 10% response rate. And to be fair, that's probably being driven by the clear cell cancer cohort. So normal high-grade serous or high-grade endometrioid cancer is not responding to single agent immunotherapy. But whether immunotherapy and a PARP inhibitor might do that is being worked out. And we had Athena in Ireland, and we got patients on this looking at rucaparib with or without nivolumab and seeing whether or not that would make a difference to that platinum-free interval. There's lots of studies ongoing, FIRST, DUO, and DOVAC, all looking at ways to harness the immune system to try and kill cancer as well. I talked about olaparib with bevacizumab as part of the PAOLA-1 study, but we've other studies ongoing looking at other antiogenics and also that PARP inhibitor versus PARP inhibitor plus Avastin, whether the Avastin is actually adding anything really. And then we have PARP inhibitors and targeted therapies like a PI3 kinase, and this is being driven by other mutations that are in your cancer, and it's this personalized cancer we talk about. So I apologize for the technical glitch, and I hope that everything wasn't too bad thereafter. And thank you so much for your time this morning.
Thank you, Dearbhaile, for that fantastic overview of PARP inhibitors. Lots of questions coming through, but we're going to save them until the end. But a fantastic overview of PARP inhibitors and treatments in ovarian cancer. So I'm delighted now to welcome our next speaker, Anne Herlihy. And Anne has been doing amazing work really for promoting awareness of ovarian cancer, and she's a fantastic patient advocate. And Anne has benefited from some of the treatments that Dearbhaile has spoken about. So I'm delighted now for Anne is going to tell us her story. So Anne, if you'd like to.
Good morning, everybody. Thank you, Sharon. Can you see me?
Yes, we can.
Okay. Can you hear me? You can. My name is Anne Herlihy. Thank you, Sharon. Thank you, Dearbhaile, for a very informative piece. I was diagnosed with advanced stage 4 ovarian cancer in 2014. It was a body blow. And on diagnosis, I was advised to get a genetic test, which I did. And it was discovered I was BRCA1 positive, which allowed the rest of my family to be treated as well. And we found out we got it from the paternal side of the family, as all my aunts and uncles had passed away with BRCA-related illnesses. And my sister was positive as well for the BRCA gene. So I started frontline treatment, which was carbotaxol. Later, Avastin was brought on the treatment plan. And I was on Avastin for about 4 months when it was discovered that it wasn't working for me anymore. The disease had progressed. So I was put back on carboplatin on its own. And I often say I was diagnosed at the right era, at the right time, because that was the end of 2015 when I had finished chemotherapy. It was discovered I was platinum sensitive. And in January 2016, which is 5 years ago, I was put on a trial for olaparib by my oncologist in CUH. And I've responded very well to that. Now, my dosage at the start was 400 milligrams twice a day, but after 4 or 5 weeks, it was discovered that it was too high a dose, because within the intervening 3-4 months, I had to get blood transfusions. it affected my my blood cells. My hemoglobin went really low. So my dosage was reduced to 200 milligrams twice a day. And I was petrified that the cancer was going to come back and come back big time by going on a lower dose. But I'm glad to say that it has kept the cancer at bay. Yes, I've had cancer return twice since then. It has been operated on and removed. And recently a new nodule has recurred in my lung. But as Dearbhaile said, it can be operated on, hopefully removed, and we go on. Previous to when I was diagnosed, there was no such thing as BRCA testing that much anyway. You could get it done privately, and treatment for BRCA cancer patients. But since I was diagnosed, it seems to be widely used now for platinum sensitive patients, and it's wonderful to see. It is wonderful to see a lot of patients now that ordinarily wouldn't have had that good time, that quality of time going on and living their lives, living with cancer. Yes, there are side effects that I find sometimes hard to deal with. Some of my side effects haven't been mentioned at all. They're not listed, but then again, it's a new enough treatment plan. But my main side effect would be acute back pain. I do have the insomnia on the olaparib as well, but I'm lucky that you can be treated for pain, so I'm able to cope with that and have a quality of life. What else? I mean, it's great that my family were able to be tested, and my sister was able to be tested and found positive for the BRCA gene and was able to get all the preventative surgery done if she needed. In the interim, my dad, who was, he hasn't been tested, but he has been diagnosed with advanced stage 4 pancreatic cancer, which is also BRCA cancer. So he's been tested shortly for that, but there's no doubt that that's what he has. So into intervening years between all the research that has been done, and I must say I have been taken around the labs years ago in breakthrough cancer research, and I was able to see the stages that they were going through on the experimenting of different treatments for recurrence of ovarian cancer. And I probably put a lot of pressure on the scientists that I was talking to, because I said to her, my life depends on you. I felt sorry for that afterwards, but it was able to see that, yes, in breakthrough cancer research in Cork facility, they are working hard for the ovarian cancer patient. And it was wonderful to see, and it was wonderful to see the petri dishes and to talk to the scientists themselves, and to know that in the future, it might be 5, 10, 15 years time, that women are going to have more options for treatment, and they're going to have the better quality of life, and hopefully a longer future. Thank you for listening.
Thank you, Anne, and thank you for sharing your story. And you have done this on numerous occasions. I heard you during the week as well on the radio. So you've done amazing work really for increasing awareness of ovarian cancer. So I'd like to invite all Dearbhaile and Orla to turn back on their cameras, and we will just start some of the questions. And I think there's a lot of questions towards you, Dearbhaile, here, but we'll make a start on this, and maybe the first question, is there anything that can be done years later, so 4 years later, if your tumour was not tested for BRCA during the initial surgery, germline tested negative for BRCA 1 and 2, but the tumour wasn't tested at the time?
Yeah, so the tumour can be tested now. So there is an NCCP pathway for looking for BRCA 1 and 2 in the tumour itself. So it can be done now.
Okay, thank you.
Another one for you, Dearbhaile. What is looked at in deciding the risk of inherited cancers in a particular family?
So I think really what's really important is for years we used to have grading systems for your risk of ovarian cancer, and I think it's become really clear, in particular with ovarian cancer, that you can have a BRCA 1 or 2 mutation inherited and have no family history. So which is why all patients are being offered the testing. So while it's not always BRCA 1. There's a small, I mentioned there was a small sort of, extra, there are other inherited abnormalities that can be, and they're rare. So really we're looking at for close family relatives, so mothers or sisters or brothers that might have cancer. It doesn't really matter the type, and it's worth certainly discussing with your oncologist about your family history and going through the ages. So, but generally inherited cancers happen when you're younger, and it's the closer ones. So having cousins, distant cousins that have cancer probably doesn't mean you have a high risk of an inherited test. But for the BRCA, certainly everybody should be tested anyway, irrespective of their family history.
Okay, that's great. Thank you very much. Another question, I'll give another one to you, Dearbhaile, there. Fantastic talk and presentation. I'm finished platinum-based chemo 3 years ago for stage 3B ovarian cancer. I'm BRCA 1. Is there any point in starting a PARP now, or would I have to wait for a relapse?
So I suppose we don't know the answer to this. We haven't studied this. So I would feel that you'd be best waiting. The studies that we have are maintenance. We usually start the PARP inhibitor within about 6 or 7 weeks of completing chemotherapy. So I think that going on it now probably won't have any benefit, not that we know of anyway, but would add obviously side effects. So waiting, we talk about waiting for a relapse. Sometimes the BRCA-driven cancers, their platinum-free interval is actually can be quite a long time. It can be years, and may not relapse. That's the other thing.
Yeah, that's a question that's come up a few times, Dearbhaile, for us just in our Ovacare coffee and chat, is that length. You said you usually started within 6 or 7 weeks of finishing your chemotherapy. Is there, what's the outer limit of that, because a lot of women ask that, if they're feeling very unwell after they've finished their chemo, and how far can you stretch that out to, or is there a limit?
Yeah, so I suppose we have guidance from the NCCP, which is being driven by the studies. But I think in reality there should be a degree of flexibility depending on how people are recovering from their treatment. But usually it's between kind of 6 and 8 weeks after finishing chemotherapy we get it up and running. But if there are delays for whatever reason, I think that they're because of recovering from side effects or something, I think that there can be a flexibility of a few weeks thereafter. But once it started to stretch out, kind of 3 months after finishing chemotherapy, I'm not sure whether starting the PARP inhibitor at that stage would be the right thing to do.
Okay.
And there's less questions for you, but I did want to give a lot of comments that came in, which is all about how that your comments were really interesting and insightful, and how inspiring you are. There's a raft of comments coming in, and what an inspiring person and you are for sharing your story. So they're all the comments to you. And look, I have another question for you, Dr. Collins. I'm wondering what advice you would give for family screening. My sister had ovarian cancer, no history of breast cancer in the family. I know the CA125 is now a definitive test, but should we have annual pelvic scans, or is there benefit to it?
There isn't, I'm afraid. We have screening for ovarian cancer has not been proven to pick up ovarian cancers, I'm afraid, and that's the big problem with this cancer, is that there is no solid screening test. CA125, as you said, it's not reliable. And even pelvic ultrasound. So there has been studies comparing whether or not we are trying to, there are ongoing studies looking for ways in which we can screen for ovarian cancer better. I suppose the question is, as regards your sister, whether she was tested, if she had ovarian cancer, should she have been tested for BRCA, as all patients should be? And then if she was negative, then that would be obviously, that would mean that you would be negative.
And just a question for you, has the knowledge that you had a BRCA mutation, has it had a lot of implications for your wider family?
It has. Now, it was a shock to hear that I was BRCA positive, because of course I was thinking my children are going to get all these cancers, they're going to die, etc. And it was a big responsibility for me, and especially when I was given the positive result. So my sister was tested, she was positive, but the way she looked at it was, I saved her life. Because if I hadn't been tested, nobody else in the family would have been tested, and they could have gone on to get either breast, ovarian cancer, whatever. My sons were tested, they were negative. So I know it's not gone down the line. My brothers were tested, they were negative. So it seemed to be only the girls that were positive from my father's side of the family. So he passed it on to the girls, his daughters, but the sons were negative. And I know that probably years ago, my dad should have been tested because he was diagnosed in 2011 with prostate cancer. And all his siblings had passed away from either pancreatic, prostate, or breast cancer. But it wasn't there at the time. It wasn't available at the time. If it was, as he said, major changes would have occurred. But now he's terminally ill with pancreatic cancer. I've got advanced ovarian cancer. My sister has preventative surgery done, a huge operation for her to do. But being BRCA, I think it helped me, and it helped my family knowing that there was treatment there for BRCA positive patients. And that it's after giving me that length of time. I mean, I was told at the start that I was inoperable and incurable, but since going on BRCA gene, the BRCA, treatment, the olaparib, I was able to have 2 major surgeries, which were beneficial to me, and it actually made me feel better. I know it's not good to have the cancer come back, but to know you can actually be operated on to remove it, and you could be clear again for another year or 2.
A question there, so for Dearbhaile, this one is great talk, Dearbhaile. Sorry for the nerdy science question, but do you know if ovarian cancers are currently screened for cyclin E overexpression? About 25% of cases, I read somewhere that this can affect PARPi in responses.
So we're not actively screening for cyclin E overexpression or for any of the other. There are some other biomarkers which may make PARP inhibitors more likely to work. So I suppose, like, I mean, even HRD testing is not perfect for identifying the group of patients that respond to PARP. And even BRCA patients, there are some BRCA patients that are not responding to a PARP inhibitor. So what, you know, I mean, ultimately we'd probably end up with a signature, a wider signature that will help identify patients that might respond the best. But actually what's been really simple and has been the best predictor of response to PARP inhibitors is sensitivity to platinum. So it's the response to the chemotherapy, and patients who respond to the chemotherapy, that, you know, that's almost the best biomarker we have right now. And that's why there's all these fancy tests coming down the line, fancy expensive tests. But ultimately, you know, in my practice, I'm trying to get all my patients who've responded to a platinum onto a PARP inhibitor, because I think the biomarkers are lacking. And, you know, I think that the benefits of the PARP, if it does work, are you know, phenomenal.
There's another question here. Have high-grade serous have had successful carboplatin and surgery, not BRCA positive, so commenced on Avastin, but unfortunately due to blood pressure problems, despite medication, have to stop it after 4 rounds. My plan now is if cancer comes back, have chemo and then a PARP inhibitor. Which one is likely to be used?
So BRCA positive patients receive olaparib currently with the reimbursement, and BRCA negative patients will be on the Zejula drug, so Niraparib. So that's what we have currently licensed. And hopefully as we move forward in the future, we'll have more of a choice. But for BRCA negative, high grade, platinum sensitive ovarian cancer, Niraparib is the way to go. And then talazoparib is the one for breast cancer, BRCA breast cancer. We have lots of them around. Oh, no, none of them easy to pronounce.
I'm glad you're saying them and not me. And I have a question for you. Dr. Khan spoke about it earlier about, trying to balance toxicity with effectiveness, and side effects for a patient. If there are researchers who are listening today, what are the kind of side effects that you've experienced that you think these are the ones that would be the most important to try and keep in mind to reduce if people were designing new treatments into the future, the ones that have had the greatest impact to you personally?
Well, I seem to develop a lot of chest problems, lung problems, which can make you breathless, of course. Since my dosage was reduced, I have never again suffered from low hemoglobin. The back pain is, I've spoken to a lot of women through networking all over the world. Many of them suffer from acute back pain from the olaparib. And the insomnia, of course, that's a huge, because when you can't sleep, you can't operate properly the following day. That's my excuse for not doing housework. And dry skin, that seems to be a major issue with a lot of us as well, is very dry skin and brittle nails. That seems to be, from the women I've spoken to from America and all, many of them suffer from the same thing, very dry skin, brittle nails, insomnia and back pain, as well as, now the other ones haven't affected me, the nausea, the headaches, the high blood pressure, etc. But these did affect me and a few more women that have been on the drug. But I think it's only happened mostly in the last year that all these symptoms have come. And it's probably a build-up of the drug, because also within the last year, I've lost my hair. My hair died and started to fall out, hence the wig today. So it has built up, but it hasn't affected me in a way that my cancer is still dormant, because I'm getting scans very, very often. And it has showed that my cancer is still dormant in the aparted places. And that's all that worries me. And that's what keeps me going.
Absolutely.
Great. That's great. Just another one for you, Dearbhaile, there. Has there been any research into effectiveness of PARP inhibitors in ovarian cancer in Lynch syndrome patients?
So I suppose Lynch syndrome is a different, they also have problems with their DNA repair, but it's a different profile. So a lot of the research with Lynch has been driven by immunotherapies. So we're definitely seeing patients who have abnormalities in their mismatch repair proteins, which is what leads to Lynch, are particularly sensitive to immunotherapy. So, I mean, I suppose, you know, that would be that's where most of the research is heading in that cohort. I haven't seen, nothing with PARP inhibitors alone is springing to my mind. But it's because it's very much, it's a cancer that immunotherapy is really coming to the fore in.
Okay, thank you.
There was a question into the chat there about, is there any diets you'd recommend for people who've gained a lot of weight while on treatment, or, you know, where there's a good place to get proper advice on managing weight?
Yeah, so I mean, there's no special diet that, you know, that can reduce, that we know of, that can reduce cancer progression, prevent cancer from coming back. So really what I would always recommend is a healthy diet, eating well, and just, you know, I suppose maintaining good health. So when it comes to trying to lose weight, which is actually can be a common occurrence when, with chemotherapy, and there's often steroids involved with chemotherapy, and then, with treatments thereafter. It can, it is really just trying to work with exercise, which is really important, calories. And Orla, I don't know whether you want to say something about the cancer cookbooks that Breakthrough Cancer has been heavily involved in.
Yeah, we have produced a series of cookbooks with Dr. Aoife Ryan in UCC, and therefore people going through treatment and post-treatment, and they're all based on evidence because, during treatment, a lot of preservation of muscle is incredibly important, and high protein, and people who have weight loss can actually have negative impacts on their bodies. So if you go onto our website, you can find a tree that talks about which thing you might be experiencing, and it can direct you towards the appropriate thing. But all of that has to be done really in conjunction with your doctor, who's the person who has the whole history of what's happening. But there isn't a magic diet, and people's needs change as they're going through treatment as well. So I think the important thing is to try and be as healthy as possible, because obviously there's a lot of other things going on, and not putting additional pressures on the body at the time is probably the main thing.
Okay, there's another question here, Dearbhaile, for someone who's BRCA negative post-chemotherapy for up to the stage 4 ovarian cancer. Are you automatically commencing PARP inhibitors above Avastin for maintenance therapy?
So at the moment, the NCCP reimbursement for BRCA positive patients is for olaparib maintenance. So that's based on the SOLO1 study. But for BRCA negative patients, it is still relapsed disease. So the study, so it's Niraparib, which is reimbursed, but it's at first relapse once the once the cancer is still sensitive to the chemotherapy. The PRIMA data was only came out there at the end of last year, and the PRIMA data is looking at Niraparib or as maintenance after the first treatment, but that was a high-risk cohort and a high-risk group, so it's not reimbursed. It's not officially reimbursed currently. So I suppose it's a conversation that you can have with your oncologist about, maintenance. And Avastin, it still has a good efficacy rate at keeping the cancer in remission. It's not as good as the PARP inhibitors, tends to only, keep it at bay for, a few months kind of longer. And it has side effects. I know some of the questions have talked about, the high blood pressure, and it does have side effects. So Avastin is, again, it's not for everybody, tends to work better in patients who are higher risk of the cancer relapsing. But currently I suppose the licensing is Niraparib second line. There is a question come up about rucaparib versus Niraparib. So from about 2018, we had compassionate access by Clovis Oncologist for rucaparib. So we applied to Clovis Oncologist for oncology for our patients with platinum sensitive disease who are BRCA negative. So for the last basically 3 years, all my patients have been going on to rucaparib. I think it was February, the 1st of February, I think, we got access to Niraparib. So literally we just, and it's reimbursed. It's not a compassionate access program. So compassionate access programs take a lot of paperwork, and a lot of, the drug has to be shipped in from England, and it had to go through the hospital pharmacy, whereas Niraparib now can come out of your community pharmacy. So it's kind of easier. But that's why some people might be on rucaparib and Niraparib. It's just a timing thing.
Okay, thank you.
For Dearbhaile, there is, if developing an early detection test for ovarian cancer, is it wise to also incorporate biomarkers for the types of cancers under the ovarian cancer umbrella, such as fallopian tube cancer?
Yeah, so fallopian tube cancer and ovarian cancer are the same thing. In fact, there is a wealth of evidence to suggest that actually ovarian cancer doesn't actually start in the ovary. It actually starts in the fallopian tube and drops into the ovary. So we do treat them the same. There's another, cancer concept called primary peritoneal cancer. And they all more or less, once they're on the serous or endometrioid spectrum, they all look kind of the same under the microscope. They respond the same to PARP inhibitors and treatments. So fallopian tube cancers and ovarian cancer are very much in the same sort of treatment. I mean, for the future, we need biomarkers. We need ways in which we can detect cancers earlier, ideally through blood tests, so through liquid biopsies. And there's loads of work going into this and research around the world. But because, if you remember, like, cancers are quite unique. So I talked about my umbrella of ovarian cancers, and they all have different mutational profiles. So it's hard to, you know, even if you had a biomarker for high-grade serous ovarian cancer, you could take a blood test for it, you mightn't pick up a clear cell cancer. So it's very complicated. It's very, there's a lot, I suppose there's a lot of research needed before we get to that point. But you know, I mean, there is lots of work being put into it.
Great. Sorry, another one, Dearbhaile now. Is there an age that someone should have BRCA screening at, and can the GP do this?
Well, I mean, if you have a BRCA mutation in your family, they usually offer screening once you're 18, but that's driven by a genetics unit. So like a genetic unit is it's a real multidisciplinary team. There are genetic counselors, there's oncologists like myself with a speciality in genetics, in cancer genetics, and then there's geneticists, so patients or doctors who just specialize in the genetics. So it's a big group of lots of different people who are so even though I am now testing my patients for BRCA at their diagnosis, their tumor and their blood. So I give them a sort of, you know, I suppose the rudimentary why we're doing this test. There are leaflets from the NCCP that we hand them. And I do very basic counseling, as in, these is the implications of this test if it does come back positive. But then if I do find a BRCA mutation, that patient then gets referred to a genetics unit where there is a multidisciplinary team there to help with, I suppose, coming to terms with the diagnosis, what that means, you know, prophylaxis, you know, should you know, we consider risk reducing surgeries, and then the implications for the wider family. But once people are over 18 and there's a known BRCA mutation, they can get tested. I was flicking through the questions there. Yes, so there's a question about how long is the waiting time for appointments. So, yeah.
Yes.
So for the BRCA 1 and 2 testing if you have ovarian cancer, for BRCA 1 and 2 testing, there's no waiting time. Your oncologist does that. I will do that. And that gets shipped, then that goes up to the genetics group, and they just test it for the BRCA 1 and 2 mutations. That comes back. Now that takes a while to come back. It takes about 4 or 5 months to come back, which is why it's important to get it done at the start of the chemotherapy, so we know by the time you're finishing chemo 6 months later. But if it comes back negative and there's still this really worrying family history, then a referral to the genetics group in James's or Crumlin should still go ahead. Now that waiting time is significant. I mean, it's probably over a year, if not 18 months, if not even more. And that's something that the National Cancer Strategy, the NCCP are aware that there's a big kind of unmet need to start to resource the genetics in Ireland much more heavily, and that will happen in the future.
There's a question here for Anne. When testing for cancer recurrence, so like if the cancer has come back or you're being surveilled, what is this process like? Is it very difficult and a long process? I would really like to understand what it's like from the patient's point of view, because I'm totally inspired by you.
Thank you. Well, for recurrence, I'm very lucky that once you're in the system as an ovarian cancer patient, and because I'm on a PARP inhibitor, I'm seen very regularly by my oncologist every 8 weeks. And I think it's every 3 months I have a CT scan. So that will pick up anything that's occurring. Or with me, I am so lucky. My CA125 is my signal there's something wrong. Because even if it goes up by 1, we know there's something happening. And if it goes from, it's usually 12, if it goes up to 20, we know, even though 35 seems to be the cutoff point, you know, that you're safe. With me, it seems to be once it goes up 1 or 2, there's something happening. CTs with me are performed maybe 4 times a year. And if things are unclear, I might get the PET scan, which is a more in-depth test. then it's the oncologist, it's in his hands, and he decides what to do. Now, I have never been taken off of the PARP inhibitor. I've had the surgery. It's a blow to get when the cancer comes back, an absolute, you think your life is just a matter of months, that's all you have. But you get great comfort from your oncologist and the multidisciplinary team that work on you. And once the surgery is done, I have had 2 radical surgeries. They've told me, yes, we found the cancer, but now it's gone. And you're clear again, and it's dormant again. And off you go and enjoy your holidays. And that's it. I'm happy then until the next time. And I know there's probably going to be a next time, but I had 9 months between 2 surgeries, and now I'm going on to 2 years since my last surgery. So to me, that's a good bonus.
Great. That's very yeah. Just another one for Dearbhaile there. Would you be able to comment on any results coming from clinical trials using immunotherapies in combination with other treatments for advanced ovarian cancer, including platinum-resistant disease?
So originally, I suppose that PARP inhibitor plus immunotherapy. So all these drugs start out in platinum-resistant disease, the majority of them. They're tested in a range of different cancers. And I spent a number of years doing a fellowship in an early phase drug development unit. So this is how these drugs are developed initially. And then they generally move forward or move earlier. They move into, I suppose, earlier time points in the cancer progression, and sometimes all the way to the start. So when the cancer is actually resected. So PARP inhibitors plus immunotherapy originally, so immunotherapy was presented, and there's a Keynote 100 study about a 10% response rate. Again, as I said, being driven by the clear cell cohort. So really immunotherapy on its own, not good for the high-grade serous and endometrioid cancers. Now, I am accessing it for my clear cell patients, as are, I believe, most oncologists. But PARP inhibitors with immunotherapy first came to the forefront in a trial called Tapatio, which showed an improvement to about 25% in platinum-resistant cancers. This was fantastic, practice changing. We were like, oh my God, this combination is really going to work well. And what's important is they don't have overlapping side effects. So, a nice group to bring on. As we've moved it forward, we're still figuring it out. So Athena and Duo and the first study, they're all still ongoing. We're all expecting them to reach out about whether these are all platinum sensitive. So I suppose platinum resistant disease, there's research ongoing on it. It's really novel drugs we need for platinum resistant disease. There are some excellent antibody drug conjugates being developed. There's a drug called tisotumab vedotin, which is being tested, and we had the study. It's in Ireland. And these are showing real promise in platinum resistant disease. But platinum resistant disease does need more options. It needs more drugs and more research to find more drugs, because it is a harder cancer to treat and manage. I hope that answers your question. I went through about 4 different concepts. Topics.
I think it did. I think it might have answered one of the other questions there about platinum resistant disease. But maybe just following on from that, do you ever see a stage where PARP inhibitors might be the first line treatment, as in instead of chemotherapy?
I don't know. I think chemotherapy will always hold a backbone, and carboplatin in particular in high-grade serous ovarian cancer. So Niraparib is available in other countries, in the US, as a treatment. But it probably won't, it's not available in Ireland. We're using it as maintenance, and really as things are moving forward, it's in maintenance. Now the question is whether adding it to chemotherapy, and there's been studies with veliparib, a study called Velia, and that showed that adding veliparib to chemotherapy and then continuing veliparib had excellent outcomes. So all those studies are starting to read out, and we're starting to to learn more about where PARP inhibitors fit. The problem with PARP inhibitors and chemotherapy is they both have the same side effects, as in your nausea, vomiting, fatigue, affecting the blood counts, dropping the platelets. So it's harder to deliver PARP inhibitor with chemotherapy. you know, I mean, for some cancers, carboplatin is an excellent drug for these cancers that are driven by BRCA. And, you know, certainly we use it even in prostate cancers driven by BRCA, in pancreatic cancers driven by BRCA. We're more inclined to use a carboplatin or something like that. So yeah, so I mean, you know, chemo will always have a place in ovarian cancer.
Okay, thank you.
A question for you, Anne, there. Obviously, as part of today, one of the messages that people are trying to get out and get people to share is an acronym called BEAT, which talks about the symptoms to look out for, because they can be often quite vague and, you know, easily kind of put off as something else. Would you be able to talk a little bit about the symptoms that you experienced that if you look back on now, maybe were signs of things to come that you mightn't have like linked at the time, but people could be keeping an eye out for if they haven't had ovarian cancer themselves?
Okay, as we know, some of the symptoms can be very benign looking. You know, I had lower back pain, groin pain, but I was putting that down to, I was decorating a house at the time and I was going up and down the ladder. So to me, that's what that pain was. So why go to the doctor? Then I gradually noticed I was putting on some weight. I was kind of feeling bloated. And my appetite just near the end, it just went completely. I mean, even the girls at work noticed I'd eat one biscuit, half in the morning and half for my lunch. And I felt full after those small pieces of biscuits. And I was putting that down to gluten intolerance. I was putting it down to the menopause, and everything just goes haywire during the menopause. And chronic constipation, absolutely change of bowel habits, frequency of urination. I couldn't go outside the door, but I'd have to run back to go to the toilet. So with the BEAT campaign, you had the bloating. Yes, I had that. Eating habits. I felt full after eating small morsels of food. I didn't have an appetite. If I did eat over what I was able, I felt that I got heartburn, a lot of heartburn. The abdominal pain, that could have been put down to anything, but it was part of ovarian cancer. I didn't know the symptoms. And the toilet changes. So by the time I was diagnosed, I looked like somebody that was 3 months pregnant. I was constipated. I had aches and pains. My quality of life was non-existent. I was still working. I was tired. And when I was told by a doctor, not my GP because she wasn't there, but I was told I had a middle-age spread when it was July. And by September, when I was diagnosed, I had 2 stone of malignant fluid in my abdomen, which had spread to my peritoneum, a word I never knew where in my body. I had a peritoneum, omentum, chest cavity, lungs, fallopian tubes, ovaries, lymph nodes. And when you're told that, and when you're told it's advanced, and when you're told 3 out of 10 survive to 5 years, all you want to do is slump in your chair and, you know, just let things go. But there's more awareness out there now. And I'm still here going on for 7 years. And there's hope. And I think awareness and knowledge of your family's history is number one. I think if you know your maternal and your paternal illnesses on their side of the family, I think that's a major bonus. And knowing the BEAT campaign that can be seen online on the Overcare site and the Breakthrough Cancer Research site and social media.
Thanks. I think that's a great note. But you know, we would really encourage, I suppose, people to share the BEAT campaign on social media. You know, get the message out there. So yeah, I think that was great. Yeah. I think we're nearly, there might be 1 or 2 more, maybe, Dearbhaile, if you're still willing to answer. Was diagnosed with ovarian cancer 10 years ago and the BRCA test was negative. Very strong family history of prostate in the family, which wasn't included under the BRCA umbrella 10 years ago. Would BRCA retest be recommended for the benefit of my own sisters and child?
I think a genetics referral just an actual genetics referral, so they could do the BRCA testing, but also look for other potential mutations. So there is a number of different BRCA mutations that can develop, and there are some BRCA mutations that actually don't cause cancer, and there are some BRCA mutations we don't even know if they cause cancer or not. So there is a change. The BRCA does change, and also the way we test changes. So being tested 10 years ago, I would think that if you get, when you get up to the geneticists, which you should with a family history, especially if it's, of young first-degree family history of younger people involved, but that they would probably retest, but they can do others as well, you see.
Yeah. Okay.
I think we're done, are we, with the questions?
Yeah.
You might get your afternoon back. Wait, there's one maybe into the Q&A.
Oh, this one.
Yeah, quick question for Dearbhaile. You mentioned a drug for platinum-resistant patients, something Vedotin. I missed the first word of the drug's name. Again, we're glad you're pronouncing all the drug names, Dearbhaile.
Yeah, so there's a few drugs in testing for platinum resistance. So I suppose there's the tisotumab vedotin. It's a stealth bomb chemotherapy. So it attaches. It's an antibody like Avastin is, but it's got a bomb of chemo attached to the end of it. And what it basically does is it travels around the body, attaches to wherever the receptor is, which is it's more likely onto a cancer cell, and explodes the chemotherapy into the cell. So these targeted chemotherapies are on the way. We're also looking, ovarian cancer has a high expression of something called folate receptor. So actually we also had another study called Soraya looking at a folate receptor inhibitor, again, another antibody, again, another bomb of chemotherapy at the bottom of it. HER2 expression and HER2 mutations exist in ovarian cancer. And there are, trials ongoing looking at those. So there are other things being developed, thank goodness. But it's going to take a while for some of these studies to read out and know exactly where they fit. But I think in another, maybe 2 years, we should have more options for this cohort. But there are always trials. We're always working really hard as part of Cancer Trials Ireland, and really pushing for the gynae trials to come to Ireland, really encouraging pharmaceutical companies to try and open the trials in Ireland, in particular in platinum resistance. So we always try to have a platinum resistance study going in Ireland. And, it mightn't be open at your site, but it'll be open certainly in Dublin, usually in Cork, and then it might be open in other sites around the country as well. So just ask your oncologist. It's really important as well, because trials are not just last chance saloons. So there's always drugs, being developed and available. So just keep asking your oncologist.
And I think that's a really important, probably note to finish on there is asking your oncologist, because if you don't ask, sometimes it may not come to their mind, that you might be suitable for a trial. So I definitely would encourage women, to ask your oncologist about a trial. I think it's lots of comments coming in, really thanking Dearbhaile and thanking Anne for sharing her story. You're an inspiration, Anne, and hope is more than what Anne is giving is some of the comments coming in there. And Dearbhaile, it's just been amazing, all the knowledge that you have regarding all of the trials. So I just, from myself, I just want to thank you both for giving your time this morning on World Ovarian Cancer Day. And just to encourage, if there's any ladies who want to join our coffee and chat now afterwards, just email info@ovacare.ie. I'll pop it up again in the chat, and we'll send you the link for that. They happen every second Saturday, so the second Saturday of every month, 11 to 1 usually. So it's a bit later this morning, but new ladies are always welcome into that. So from me, I just want to say thank you and encourage everyone to share their tea lights and get on the social media tonight. So Orla, I'd like to let you.
Yeah, look, just to wrap up again, thanks so much to Dr. Collins and Anne for sharing your wisdom and your information today. Thanks to everybody for tuning in. Today's a day of kind of action and kind of focus on something that is really important all year round. If you go to Breakthrough Cancer Research's front page, there's actually the press release of an entire group of patients and campaigners who are focused on this message, not just today, but all year round. But you can see the names of all the buildings that are lighting up. You can pull down the graphic if you want to share the tea lights and do that yourself. You can see the beat graphic and you can pull that down and share it on social media. And I think, look, we're a research charity. I think the other thing just for us to end in is that there are researchers working at the bench every single day. We're funding at least 5 projects, and most of them are about resistance, people developing resistance in ovarian cancer or looking for early diagnostics, 2 big challenges, and we're after them. So, you know, we'll keep going until we get the answer. So thanks everybody, and have a wonderful day, and shine a tea light tonight, and we'll collectively try and change things for patients with ovarian cancer. So have a good day.
Thank you, everyone.
Thank you, Orla. Thank you, Sharon.